So, good evening, everyone. I would like to thank all the attendees, and I hope that you get the most out of this course. I'm going to give two lectures on osteosarcoma and Ewing sarcoma, discussing the natural history and recent updates in management. Osteosarcoma is a tumor formed of malignant spindle cells that produce osteoid tissue. It is described as osteosarcoma no matter how much osteoid is produced by the malignant cells. This is very important to stress upon. In this H&E slide, here we can see this pink amorphous material, which we named the malignant osteoid, and is directly produced by the adjacent malignant spindle cells, which can show various degrees of atypia and mitosis. So these cells are directly producing this osteoid, and this is the hallmark for the diagnosis of osteosarcoma. It is important to note that even if this osteoid is scanty, still the diagnosis of osteosarcoma could be confirmed, because we should note that the extracellular matrix of osteosarcoma, the matrix produced by these malignant cells, may not be only formed of osteoid tissue. It can also include cartilage tissue, fibrous tissue, as well as other types of tissue, and would still be diagnosed as osteosarcoma as long as we see even a small part of osteoid in the slide. Certain genetic and epigenetic factors can predispose to osteosarcoma. The prevalence of the disease in the adolescent and tall patients and the localization of the tumor close to the growth plate make us suspect that the rapid bone turnover may be a predisposing factor to this type of tumor. Exposure to radiation is an important predisposing factor that can lead to the tumor in up to 3 to 4% of the patients, and can develop even up to 30 years after the exposure to radiation. It is dose dependent and is becoming increasingly seen in patients due to the large number of patients being treated by irradiation from other type of primary malignant tumors. Paget disease of bone and fibrous dysplasia are a bone disease that can lead to osteosarcoma in less than 1% of patients. Certain hereditable disorders, family disorders like the Lee-Romani, retinoblastoma, and Rockman-Thompson, as well as others, have high prevalence of osteosarcoma among their patients. Osteosarcoma can be classified according to the histologic grade into high grade, low grade, and intermediate grade osteosarcoma. This classification is important when we are going to discuss the treatment, because low grade tumors can be treated by surgery alone, while high grade and to lesser extent intermediate grade tumors should be treated by systemic chemotherapy as well as local surgery. The most common type of high-grade osteosarcoma is the high-grade conventional intramedullary osteosarcoma. This is seen in over 80% of patients diagnosed with osteosarcoma. It includes various histologic subtypes like the osteoplastic, chondroblastic, and fibroblastic. As we discussed before, the extracellular matrix of the tumor can be formed of one or more of these three histologic subtypes, and it is dependent upon the predominant type that the tumor will be given its name. If the predominant component in the extracellular matrix is cartilage, then the tumor will be named chondroblastic osteosarcoma. If it is bone, it will be named osteoblastic, and if it is fibrous, it will be named fibroblastic osteosarcoma. Other rare variants of high-grade intramedullary osteosarcoma include the telangiectatic osteosarcoma, the small cell osteosarcoma, and very rarely the epithelioid and giant cell-rich osteosarcoma. Also, other different types from the conventional high-grade osteosarcoma, which are also high-grade, include the high-grade surface osteosarcoma, the secondary osteosarcoma, the extraskeletal or soft tissue osteosarcoma, and the multicentric osteosarcoma. All these are high-grade tumors and should be treated in addition to the local control by surgery with systemic chemotherapy also. In the low-grade tumors, the most common is the Periosteal osteosarcoma, seen in less than 5% of patients with osteosarcoma, and the very rare entity of well-differentiated low-grade intramedullary osteosarcoma. And both of these tumors can be treated by local surgery only without systemic chemotherapy. Regarding the intermediate grade periosteal osteosarcoma, which is a very rare type of osteosarcoma seen in less than 2% of the population of osteosarcoma. This tumor, as being intermediate in grade, still has controversy whether systemic chemotherapy should be used in addition to local control by surgery, or the patient should be treated by surgery alone. Now we're going to discuss the conventional osteosarcoma, high-grade osteosarcoma. It is most common in children and adolescents between the age of 10 and 20 years, and the prevalence has been estimated to lie between 4 to 5 patients per million population. It predilects the long bones and very rarely involve the axial skeleton. In the long bones, it has a predilection for the metaphysis in 90% of the patients and diaphysis in 10%. The most common metaphysis involved is the metaphysis of the distal femur, followed by that of the proximal tibia and the proximal humerus. The location in the pelvis is very rare and is associated with a very poor prognosis and can be seen in less than 5% of the patients. Patient is usually presenting with severe pain, not related to activity, requiring strong analgesia, and associated in some patients with loss of weight and loss of appetite. And if the patient is presenting at a later stage, swelling could appear at the site of this pain. When we examine the patient, we have to look for the site and size of the swelling, the overlying skin, whether there are scars of previous surgeries, and the associated joint and or limb deformities. Large-sized tumors can be associated with a flexion deformity or marked edema of the limb. After clinical examination, we order our panel of investigations prior to going to treatment. Complete blood picture is not diagnostic, but may contain important information like the anemia, since the patient may have severe pain, loss of weight, and loss of appetite, which should be corrected upfront at the time of treatment, start of treatment, and the markedly elevated level of alkaline phosphatase, which indicate the rapid bone turnover produced by this malignancy. And then we order our list of radiographic investigations, including the plain X-ray, the MRI, the CT chest, bone scan, and finally the biopsy. PET-CT is increasingly becoming used to diagnose or stage malignancies, and we prefer to stick to the standard of care, which is currently the CT chest and bone scan, and restrict the use of PET-CT only to cases in which there are controversies in the diagnosis or the staging of the patient. So based on the imaging investigations we did, whether locally and systemically, we can stage the patient. The Musculoskeletal Tumor Society staging system is based on 3 items: the histologic grade of the tumor, whether it is a low-grade tumor graded as grade 1 or a high-grade tumor graded as grade 2, named as grade 2. And compartmental localization of the tumor. If the tumor is intraosseous and has no soft tissue extent, it is T1. If the tumor is extending extraosseous into nearby tissue, it is known as T2. And finally, M is for the presence or absence of metastasis. And any patient with the presence of metastasis is classified as stage 3. Most of the patients present in stage 2B, meaning that most of the patients are non-metastatic, high grade, and the tumor has an extraosseous extent. 15 to 20% of the patients present as stage 3, indicating the presence of metastasis. And most of these metastases are located in the lung. Bone metastases are rare and carry very poor prognosis. Organ metastases, like the liver, are extremely rare in bone sarcomas. Now, after ordering the X-ray, here we should notice, first of all, the presence of the physeal plate or scar, which indicate that this patient is either an adolescent or reaching maturity patient and fits the epidemiology previously we described in osteosarcoma, the age group. Second is the location in the metaphysis. And we said before that the osteosarcoma predilects the metaphyseal region of long bones. Third, we start to describe the tumor. Osteosarcoma can be sclerotic, lytic, or mixed. containing areas of both sclerosis and lysis. And being a malignant tumor, rapidly penetrating the nearby cortex and the periosteum and extending into nearby soft tissue, it can lead to abnormal periosteal bone formation in the form of Codman triangle. All these criteria can be diagnostic for an osteosarcoma. Finally, we should note if there is any existing pathologic fracture so that the patient limb could be immobilized during his investigations and during the course of his treatment until the time of local surgery. In the X-rays, osteosarcoma can be misdiagnosed into other types of tumors, like Ewing sarcoma, where the tumor can be a highly permeative lytic lesion in the metaphysis, and then this can be misdiagnosed with the lytic type of osteosarcoma, especially that the Ewing sarcoma predilects the same age group of patients and the same anatomic location and can have both intra and extraosseous soft tissue component. And in such cases, the diagnosis would rely predominantly on the biopsy and the histologic picture. Osteomyelitis in neglected cases, long-standing cases, can lead to extensive periosteal reaction and intramedullary areas of sclerosis with lysis, and can be misdiagnosed with the sclerotic type of osteosarcoma. In such cases, in the absence of frank clinical picture of infection with the sinus discharging pus, patients are also diagnosed based on the biopsy and the histologic picture. Myositis ossificans is a very rare entity that developed after trauma, whether natural or surgically induced, characterized by abnormal bone formation in the soft tissue adjacent to a long bone. This abnormal bone formation, if seen at the mature phase of myositis ossificans, we can see that the bone is well organized and is separated from the nearby bone or cortex by a radiolucent space. Aneurysmal bone cyst is a benign aggressive tumor that can develop in the metaphysis of long bones in children and adolescents and can extend into nearby soft tissue. It is a completely lytic lesion that can be misdiagnosed with a telangiectatic osteosarcoma, even after doing the MRI pictures, and the diagnosis is also based on the histology. Finally, Periosteal osteosarcoma is a sub-entity of the variants of osteosarcoma, which arise from the inner layer of the periosteum of the long bone. Most common site is the distal femur. It extends usually into nearby soft tissue. Very few cases, less than 20%, extend into the medulla. And it's very important to differentiate between it and the classic conventional high-grade intramedullary osteosarcoma because its surface location or just a cortical location, which may differ in the planning for surgical resection. And the second thing is being low-grade in nature, so it does not require treatment with systemic chemotherapy, and the mainstay in treatment is the surgical resection with wide margins. After doing the X-ray, we continue the local investigation by doing the MRI. MRI complete the picture with a very accurate assessment for the local extent of the tumor. It can help in planning for biopsy, planning for the intraosseous extent, as well as the soft tissue extent, and our bony and soft tissue cuts to achieve safe surgical margins. It also can detect the relationship between the tumor and the important nearby neurovascular structures, nearby joint, whether it is involved or not, and to detect skip lesions. Skip lesions are other lesions similar to the tumor that arise within the same bone or in the nearby bone. These lesions are usually an extension, direct extension of the tumor across the medullary canal or the nearby soft tissue and ligaments, and should be treated by surgical resection at the same time with the primary tumor. After doing the local imaging, we go for the systemic imaging to look for distal metastasis. As we discussed before, the most common site of metastasis are the lung and bone. This is why we do a CT chest and bone scan to detect these lesions. Finally, before starting treatment, we should confirm the diagnosis of osteosarcoma, even if we are sure radiographically that this is an osteosarcoma. Most of the biopsies are currently done as true cut or core biopsies, and the operator can see the lesion and sample the representative part of the tumor under sonar or CT guidance. It is conclusive in over 90% of the cases and is indispensable in deep locations like the spine and pelvis, where open biopsies are extremely difficult. Open biopsy has still role in the assessment, histologic assessment of the tumor in situations where true cut biopsy is not possible, either because the tumor is very hard in consistency or the tumor patient presents at an early stage with an intraosseous tumor and an intact cortex that is difficult to be breached by the true cut needle biopsy. In such situations, open biopsy can be done, provided that the surgeon follow the rules for open biopsy and avoid the contamination of the nearby soft tissues and neurovascular bundles. The histologic diagnosis of osteosarcoma, as previously mentioned, relies on the presence of the malignant osteoid. What we mean by malignant osteoid is that this new bone formation is different from what we see in the normal bone. In normal bone, the osteoid tissue is rimmed by normal osteoblasts, which share in the formation of this new bone. And the surrounding osteocytes or cells show no evidence of atypia or mitosis. Wherever in osteosarcoma, the malignant osteoid is directly produced by the malignant spindle cells in between, which show areas of atypia and mitosis. In high-grade tumors, this area of atypia and mitosis is more pronounced than in low-grade types of osteosarcoma. However, as mentioned before, the osteoid is not the only type of extracellular matrix present. You can also see cartilage tissue and fibrous tissue produced by these malignant spindle cells. Very rare types of osteosarcoma include the small round cell osteosarcoma, which is difficult to differentiate from Ewing, and we will explain in the lecture on Ewing sarcoma how to differentiate between both of them. The telangiectatic osteosarcoma, previously discussed in the X-rays, can be misdiagnosed with aneurysmal bone cyst. Even histologically, it is compromised of thin septi and blood-filled spaces, and the amount of malignant spells and osteoid production may not be so pronounced and can be difficult to differentiate from aneurysmal bone cyst and need an experienced pathologist. Finally, the low-grade osteosarcoma, we see here that the osteoid has a more well-organized shape and structure, and the malignant cells in between these osteoid tissue show less degree of pleomorphism and hyperchromatosis. After the diagnosis, we start the plan for treatment. Systemic chemotherapy is an essential part in the treatment of high-grade osteosarcoma, in addition to the local control by surgery. Chemotherapy is divided into neoadjuvant chemotherapy, meaning preoperative chemotherapy, and the adjuvant or post-operative chemotherapy. The role of the chemotherapy given before surgery lies in its ability to increase limb edema and facilitate surgery for the surgeon, allow for early control of micrometastasis, and the possibility to assess after the tumor resection the response to chemotherapy, and we will explain this later. The current stay in the treatment of osteosarcoma systemically is to use multi-agent chemotherapy, more than one drug, rather than using one drug. After giving the neoadjuvant chemotherapy, the patient is restaged with local imaging and distant imaging, and the surgeon can start plan his surgery based on the local MRI. The goal in surgery is to achieve negative margins, whether this can be done by limb salvage or amputation. However, currently, due to the advances in the reconstructive techniques, most patients are treated by limb salvage surgery, and amputation is reserved only for less than 10% of the patients. After removing the tumor surgically, the patient has to complete his chemotherapy to control the micrometastasis and to achieve the dose intensity required from the drugs used. Radiotherapy has no role in osteosarcoma. The tumor is not responsive to radiotherapy, and radiotherapy use can be limited to inoperable cases or for pain palliation. What are the rules of resection? As Ainy stated, bony margins, we should have at least 2 to 3 centimeters of normal bone margins, and at least 2 millimeters of a cuff of normal tissue, soft tissue surrounding the tumor, or a strong anatomic barrier like the fascia or cartilage. Reconstruction can be done either using an internal prosthesis or a bone graft or combination of bone graft and prosthesis. I will leave these types of reconstructions to the lecture on methods of reconstruction in bone tumors. The most important thing I should mention here is that it is very important, regardless of the type of reconstruction we are going to use, to expect what is the degree of function the patient would have after surgery. Because in some situations, like very young patients, less than 7 or 8 years of age, or in complex anatomic sites like the sacrum or pelvis, surgical resection, even if with negative margins, can be associated with a poorly expected functional outcome. And in these patients, amputation may be better indicated rather than salvage. After resection of the tumor, surgeon and pathologist should look at the specimen. The surgeon should look for his margins by bisecting the specimen, looking for the proximal and distal extent of the tumor. And the pathologist should look at all the margins, look for any suspicious margin that can be close, take a specimen from this margin, and look if the margins are positive or negative in these areas. Also, in the final pathology report, the pathologist should mention 2 important criteria. First, the surgical margins, and second, the tumor necrosis. The surgical margins can be described in some of the pathology reports as negative or positive, or in others as wide, marginal, and intralesional. Negative margins are adequate margins, while positive margins are inadequate margins. And of course, we know that wide margins are the mainstay in the treatment of bone tumors, and that marginal and intralesional margins are not accepted. Second, about tumor necrosis, the pathologists look at the number of cells viable in the sections taken from the specimen, from the tumor specimen. If the number of cells is less than 10%, so we describe this tumor as responding more than 90% to chemotherapy, and this patient is classified as a good responder to chemotherapy. But if the number of viable cells is more than 10%, then the tumor necrosis would be less than 90%, and these patients would be classified as poor responders. What are the implications in these criteria mentioned in the histology report? First of all, the margins, marginal, intralesional, or positive margins are inadequate margins, and the patient should receive further local treatment to improve his margin, whether by additional resection or amputation. Tumors which demonstrate poor response to chemotherapy have poor prognosis, and the surgeon and oncologist should know that these patients are at higher risk of local and systemic relapse and should follow up them closely. Unfortunately, changing the type of chemotherapy after surgery to avoid a poor response to drugs is not currently reflected in most of the undergone randomized clinical trials. After the patient and his treatment, whether systemic or local, and develop relapse, we have to know how to treat this relapse. If the patient developed local recurrence, we should resect the recurrence with the same principles we did with the primary tumor, either by resection with negative margins, if this is possible, or by amputation if resection is not possible. If the patient developed lung metastasis, this should be treated by metastacectomy. If the patient developed both bone and lung or bone alone, these patients have poor prognosis and have very low survival and should be treated on palliative basis. What are the factors that determine the prognosis of osteosarcoma? First important factor is the stage at presentation. Non-metastatic patients have a 5-year chance of survival of ranging between 50 and 70%. Patients with metastasis to the lung have a chance of survival of 20 to 30%. Patients with metastasis to the bone have a chance of survival less than 10%. Younger patients have better prognosis than older patients. Children and adolescents have better prognosis than young adults and older adults. Osteosarcoma of the pelvis have worse prognosis than osteosarcoma of the long bones. Large-sized tumors and patients presenting late have worse prognosis than earlier, smaller-sized tumors. Poor responders to chemotherapy have worse prognosis, higher incidence of local and distant relapse. And finally, osteosarcoma secondary to irradiation, Paget, or fibrous dysplasia have also higher incidence of local and distant relapse and poor survival. I would like to thank you, and I'm open to all questions.